for this conference and for the last talk. I'm going to try and build from what I have spoken to you all yesterday as well as earlier on in the morning. So we first began with long-term cognitive consequences of critical illness, focusing on some of the potential modifiable risk factors such as delirium and the sedation management. And then earlier on this morning, we spoke about some of the guidelines and the bundles. So the PADIS guidelines, the pain, agitation, delirium, immobility, and sedation and sleep, guidelines, and the ABCDEF bundle to try and implement those guidelines into practice. And now I'm going to try and focus a little bit.
Ahora me voy a concentrar un poquito más en la sedación. Voy a hablar de
being the focus of the guidelines and try and tell you all some of the things that are coming up in the future. So the only disclosure again, I have a research grant. It ended in 2020 from Hospira, which was then brought over by Pfizer, and they make dexmedetomidine, and the studies that I'm going to talk about, some of them include dexmedetomidine. So thus far, we have learned that with regards to sedation, the guidelines tell us that assess patients for sedation level with objective tools. Do not use general statements such as moderate sedation, deep sedation, etc. We talked about the analgesia first approach. First, give the patient pain medication. If they're comfortable and they don't need to be sedated, we do not need to give additional sedation. And I'll talk about the NOCEDA study in a minute. Target light levels of sedation if you have to optimize sedation in addition to the analgesia you're giving your patients. Try and link a daily awakening trial with a spontaneous breathing trial, because that has been shown to have additive improvement in outcomes on ventilator-free days if you do it together as compared to if you do it independently. And then with regards to agents that if you have to use propofol and dexmedetomidine preferentially over benzodiazepines. There are circumstances you might need to use benzodiazepines when there are severe alcohol withdrawal, etc. And even in those situations, multimodal management has been now postulated. Pentobarbital is being used in some of these cases, etc. So think about those as alternative regimens, but benzodiazepines still might form some element of treatment in that group. So earlier this morning, we talked about a study that was done in Denmark, which was called the NOCEDA study. And the study did two things. One is in the intervention arm, they started with just morphine and haloperidol and did not use propofol. And in the other group, they had sedation with propofol and added morphine. And what they showed was that if you used just morphine alone as a starting point and added propofol only if you need it, outcomes were better. Now, the controversy with that study, even though it was a well-done study, is by the time the study got published, everybody said that the control arm was too deeply sedated. So because you use propofol and the group was a RAS -3, that group was too deeply sedated. So it was not current standard of care. So the same authors did a much larger study, and this is the study of non-sedation versus light sedation. So the previous study was no sedation using an analgesia-based approach first versus propofol. Now they did a study of no sedation with light levels of sedation in the other group. And this was in the New England Journal of Medicine. And what they showed was in the group that had no sedation, the RAS score was roughly -1. So patients were awakened to voice and were able to make eye contact for a long duration of time. And the group that had the light level of sedation, so not in the no sedation analgesia only group, which was red, the RAS level was about -2. So the delta between the two groups was now reduced because there was best practices utilized in the group that had light sedation. And when they looked at it from that standpoint, there was no difference in mortality outcomes when you had a no sedation analgesia-based approach first versus light levels of sedation. So it goes to tell you that the impact of sedation is more when current practice of care is deep sedation. Once you start doing really good practices of care where you have light levels of sedation, you're doing daily awakening trials, etc. In that case, some sedation exposure, over here, the light sedation, was not associated with worse outcomes. It still doesn't mean that you have to sedate your patients. Just think about which patients need it. And in that small subset, if you do light levels of sedation, the outcomes are as good as if you were using just an analgesia-based approach. Now, we talked about the daily awakening trial and the breathing trial, and this was the ABC study, which we discussed in the morning, but I'm going to just quickly revise it. This study did patients in the intervention arm had a spontaneous awakening trial and a spontaneous breathing trial linked together. So each day, a patient was screened for safety to make sure that they could be safely woken up. So they were not seizing, they were not having active agitation, etc. And then once they were a little awake because sedation was stopped, they were then screened for a spontaneous breathing trial. And as long as they met criteria for a spontaneous breathing trial, they underwent a spontaneous breathing trial. So a linked approach of an awakening trial followed by a breathing trial. And when you do that, it reduces the amount of sedation that you give the patient over time. So here are the doses of benzodiazepines. And you can see that the doses of benzodiazepines significantly reduced in the group that had the combined effort of both a breathing trial and an awakening trial as compared to the group that had just usual care. So the combination does reduce sedative exposure significantly. It gets people off ventilation faster. There's an improvement in mortality. And so outcomes are overall better. The other study that came around the same time as the ABC study was published was the sleep study that came out of Canada. And the attempt in this group was to try and see if you had a good protocol for sedation, does adding a spontaneous awakening trial make any difference in outcomes? So good sedation protocol with light levels of sedation, and then you add an awakening trial in the intervention arm. So protocolized sedation is your control. Protocolized sedation and daily interruption is your intervention to hopefully improve outcomes even further. And what they showed was that if you had a light level of sedation, planned at least by protocol, if you added an awakening trial, it made no difference in outcomes. Now, there is a problem with this study with regards to how much benzodiazepines was used in even the group that had protocolized light sedation. The average amount of benzodiazepine, so this is doses over here, midazolam equivalents. In the protocolized group with sedation, 100 milligrams of midazolam in a day was given to this patient, 82 milligrams of midazolam in the other group. So really, there was such high levels of sedation, there was no difference in the outcomes. In the ABC study, the total benzodiazepine use was about 20 milligrams. So as you compare midazolam usage in sleep versus the ABC study, when you have such high doses in both your groups, no difference in outcomes. If your study actually causes a reduction in the total amount of benzodiazepine use, outcomes are improved. Now, earlier on in the morning, I talked to you all about comparator studies between midazolam and propofol, dexmedetomidine and midazolam, and telling you all, how does the literature work out? Here are some of the summary studies. So this is first looking at benzodiazepines versus propofol. There are numerous studies which have found that benzodiazepines have worse outcomes than propofol. So propofol better than benzodiazepines in all these studies that are out here. A few studies that have shown that there is no difference in outcomes between benzodiazepines and propofol, but not a single study that has shown benzodiazepines has a better outcome than propofol. So if you take this thing together, you know that propofol has better outcomes than benzodiazepines in your ICU patients. Someone asked a question in the morning while we were waiting for coffee about remifentanil. Remifentanil is used quite predominantly in many European centers as their analgesic, but also as their primary sedative, so an analgo-based sedation approach. And some of the studies that have looked at comparisons of remifentanil with benzodiazepines have shown that there is an improvement with remifentanil over benzodiazepines. Again, no studies showing benzodiazepines are better than remifentanil. In our practice, we realized two things are happening with remifentanil. When we start using remifentanil for a longer period of time, patients seem to have hyperalgesia. So that is something that one needs to be careful about with use of remifentanil for a long time. The other thing that we've noticed is that a lot of patients on remifentanil infusions have both ileus and colonic dilatation. And that's something to be aware of, because we've had a couple of cases with colonic perforation because of very large Ogilvie syndrome based on remifentanil infusion. So it's something to be careful about. If you can use low dose remifentanil, at least data suggests that it might be associated with better outcomes, at least compared to benzodiazepines. And then we've talked about some of these studies with regards to dexmedetomidine. The first study, which was done by our group, the men study, compared dexmedetomidine to lorazepam and showed that there was a reduction in delirium over time if you use dexmedetomidine as compared to lorazepam. The next study, Riker, is called the SETCOM study. The SETCOM study was a larger study, 366 patients, and it compared dexmedetomidine to midazolam, showing an improved outcomes with both delirium and time on mechanical ventilation when you used dexmedetomidine versus midazolam. And a number of other studies, which I will go over briefly, especially the Jacob study, which was an important addition to the literature and different than some of the earlier studies. Again, no study showing improved outcomes with benzodiazepines as compared to dexmedetomidine. So the group that did, Jacob's group, they did two studies simultaneously. They did a comparison of dexmedetomidine to midazolam, and it was called MIDEX, and then a comparison of dexmedetomidine to propofol, and it was called PRODEX. It all appeared in the same issue in JAMA in one paper. So two studies of about 250 patients in each group, propofol versus dexmedetomidine, midazolam versus dexmedetomidine. And what they found was, with regards to depth of sedation in the studies, in the PRODEX study, the propofol versus dexmedetomidine study, more patients were lightly sedated. So RASS of 0, which means alert and oriented, or -1, awakens to voice and makes eye contact for greater than 10 seconds. More patients in the dexmedetomidine group were awake as compared to the propofol group, and more patients in the propofol group were deeply sedated as compared to dexmedetomidine. And most of you who use dexmedetomidine realize that dexmedetomidine does not get you to the deeper levels of sedation. So that's not surprising, but at least demonstrated that that is how it panned out in the study. What were the outcome benefits with regards to PRODEX and MIDEX? So the first columns up here, or the first few rows, is dexmedetomidine versus midazolam. More patients were able to communicate pain in the dexmedetomidine group. And that's not negative, because at least you can then titrate the correct approach. You can give them the pain medication instead of just deeply sedating them and suppressing any signs of pain, at least that the patient can communicate to you. More patients were cooperative in dexmedetomidine versus the controlled midazolam. And then we look at dexmedetomidine versus propofol. Again, communication of pain in the dexmedetomidine group more as compared to propofol. Patients were more arousable and they were more cooperative with dexmedetomidine. And as a result of that, when we've seen that overall results with dexmedetomidine versus propofol are similar, many of us tend to use dexmedetomidine as a transition agent. When you're trying to wake a patient up, patients getting agitated, you still need some element of tranquility in a way in your patient. You may add dexmedetomidine and it gets you off the ventilator faster, etc. So that may be a place to try and think of adding dexmedetomidine if you are having a tough time getting people off the ventilator and delirium is precluding that weaning from mechanical ventilation. So extubation in PRODEX study, which was propofol versus dexmedetomidine, was slightly faster in the dexmedetomidine group. Now it was not significantly different with regards to the R's, but it's something to think about, that dexmedetomidine might get your patients weaned off mechanical ventilator faster, especially if delirium is precluding weaning from mechanical ventilation. You do have to be aware that there is bradycardia associated with dexmedetomidine. And in almost every study that has been evaluated, there is more bradycardia with dexmedetomidine as compared to the comparator agent. Now, sometimes it's not a problem because your patients tend to be tachycardic, and the dexmedetomidine bradycardia actually gets them to a level that you might like with regards to your heart rate. But keep in mind that in men's study, which was dexmedetomidine versus lorazepam, more bradycardia, versus midazolam, more bradycardia. Midex, again, was midazolam versus dexmedetomidine, more bradycardia in dex. And Prodex study, also with propofol comparator, not statistically significant, but at least a hint towards higher amounts of bradycardia than propofol. Surprisingly, the differences in hypotension across the studies have not been that different. So while many of us think that dexmedetomidine might cause more hypotension than even benzodiazepines, at least in the clinical trials, the amount of bradycardia in all the amount of hypotension in all the studies is about the same. So keep that in mind. Bradycardia is something that you have to be aware of when you're using dexmedetomidine, not as much of the hypotension as compared to other agents when you're using one of them simultaneously. Now, what about the SPICE-3 study? If you have to use sedative agents, which ones are good comparators? We've talked about propofol and dexmedetomidine as the two agents. This is one of the largest studies. So SPICE-3 was a study that was done in over 4,000 patients in the ANZAC group, trying to compare dexmedetomidine early versus any other sedation that the patient may be getting. And as a result of being an implementation study and being done in 4,000 patients across all Australia and New Zealand, protocol compliance was not excellent. And so what you realized was that even in the dexmedetomidine group, while 98% got dexmedetomidine, which is great, 64% also got some propofol in addition, and 3% got midazolam. 7% of patients actually were on all three agents in the only dexmedetomidine group. So some cross-contamination because it was an implementation study across large number of studies. And in the control group, 60% got propofol, 12% midazolam, 20% got both of them. And there was a high level of deep sedation. There was no significant difference with regards to outcomes in the SPICE study. So with early transition to dexmedetomidine, at least when there is so much cross-contamination, there was no difference in outcomes with regards to death either at 90 days or death at 180 days. All other scores with delirium, etc., were the same. Now, one of the questions this morning that the moderator asked was, is there a concern with dexmedetomidine and age? And that stems from this subgroup analysis from SPICE-3. So in SPICE-3, when they were looking at, is age an interaction or an effect modifier of outcomes, what was seen was that in this plot, forest plot, you can see anything on the right-hand side is favoring usual care. Anything on the left-hand side is favoring dexmedetomidine. And in the younger patient population, the mortality in the dexmedetomidine group was slightly higher, with a higher rate of risk of death in that group. Now, it's a subgroup analysis of a large study, but there is at least some concern that in the younger patients, sedation with dexmedetomidine might have slightly higher mortality. The pathophysiology behind that is not known. And so I think that's where we are right now. The FDA has asked for some data to be assessed to try and see whether there is an association between dexmedetomidine and mortality or a higher mortality in younger patients. We don't know all the data, but these are the data that are available that has at least made it concerning that there may be something that we have to at least pay attention to. Now, dexmedetomidine has been studied again with being the two agents, dexmedetomidine and propofol. People have used a lot of comparator studies with dexmedetomidine. This is the DESIRE study. And the aim in the DESIRE study was to try and see whether the anti-inflammatory properties that dexmedetomidine has helps with patients with sepsis. So in septic patients, does the use of dexmedetomidine as compared to any other agent combination that you may be using reduce mortality in your patients who are mechanically ventilated and septic? So relatively good size patient study, 200 patients. They maintained dex between 0.1 and 0.7 mics per kilo per hour, which is the FDA approved dose. Most patients stayed within their group. There was some slight cross-contamination, but relatively good study design. Unfortunately, it was underpowered for the mortality outcome. But if you look at the results, you can see that in the dexmedetomidine group, even though it's not statistically significant, p-value is 0.20, the mortality, the Kaplan-Meier curves do have quite a separation over here. So some suggestion that perhaps in the septic subgroup, where you have anti-inflammatory properties of dexmedetomidine, you might have some improved outcomes with dex. So to try and answer this question, we actually conducted the MENS-2 study. So this was a large randomized controlled trial done by our group looking at dexmedetomidine versus propofol. So if dexmedetomidine had anti-inflammatory properties that might help patients with sepsis, we included only septic patients, 466 patients with sepsis, and randomized them to either dexmedetomidine or to propofol. But there was no difference in outcomes, absolutely nothing. If you can look at days alive between delirium and coma, no difference. Ventilator-free days, no difference. Long-term outcomes, no difference. Now, the one thing to realize is that all earlier studies, when they show a difference, we've noticed that the depths of sedation in those studies tend to be much higher. And as you're doing new studies, depths of sedation start getting lighter and lighter. More awakening trials are being done. The ABCDF bundle is being used. And as standard of care improves, the impact of sedation or the choice of sedation may not be as much as it was in the past. So I think the data suggesting not to use benzos, I think, is pretty strong. But then when you come to these agents, whether you're using propofol or dex, or you're using a light sedation approach, or you're trying to do a daily awakening trial, all that in the best practices tend to be pretty close and not have a major impact on outcomes. This was in 9 sites across the US. The average dose of propofol was 15 mics per kilo per minute, 1.5, so really light. Average dose of dexmedetomidine was 0.4 mics per kilo per hour. So light levels of sedation in a group that was mechanically ventilated and on sedation, and there was no delta in outcomes. No difference in mortality as well. Coming to just the last few slides to end this session is what's coming on the block. So if the guidelines have recommended non-benzodiazepine agents to be used for sedation in ICU patients, thus far, we considered dexmedetomidine and propofol as our 2 agents. But we do have inhalation agents, and inhalation agents have been, anesthetic agents have been used in Europe a lot longer than many other countries. And I don't know whether anyone uses it over here. Most of the limitations are to try and take an anesthetic machine in the ICU is difficult. We've used it in some cases where you've had severe bronchospasm, etc. We taken the machine to our ICU. But there are now large studies that are looking at either isoflurane or sevoflurane for assessment of sedation in the ICU and seeing what kind of outcomes are seen. This is one of the first large studies. This is the Sedaconda study. And the name, they were using sedation with the Anaconda device. And so the name became Sedaconda or something like that. And again, large prospective study, 300 patients, open label for European regulatory agencies, and to try and look at efficacy and safety of isoflurane in ICU patients. And what they showed was that the time spent at target sedation when you're using an inhaled anesthetic, isoflurane in this case, was as good as if you were using propofol. So achieving your target goal was better. Up here in this graph, it shows what proportion of patients were more awake. And the group that was sedated with isoflurane was more awake. They were maintained at that target level, but could be kept more awake as compared to the group that was with propofol. And the other thing that was concerning was if you were using a regimen with isoflurane, would there be a problem with pain medication? What was seen was that the opioid requirement was actually lower in the group that was on isoflurane. And the pain scores in this graph over here, showing that either on day 1 or day 3, the behavioral pain scale scores was similar in both groups, whether you were in isoflurane or on propofol. So patients were more awake on isoflurane. Patients had less opioid requirement, and their behavioral pain scores were the same, which basically would mean pretty decent outcome, I would say, for patients who are at least more communicative and interactive and still having pain relatively well controlled. There were no difference in times with regards to extubation, delirium-free days, etc. So at least a proof of concept study that this can be done in ICUs, and the scavenging systems were working and compliant with our ventilators, etc. in the ICU, unlike what is required of using an anesthetic machine in our ICUs. There are two large studies that are being done right now. So this is something that's going to come down the pipeline. The CESAR study, sorry, the figure didn't come over here. The CESAR study, which is SESAR, and it's for sevoflurane for sedation in ARDS patients, taking patients who are significantly sick, ARDS with PF ratios less than 150, and who are not paralyzed, are being randomized to either sevoflurane or propofol to evaluate a number of outcomes. So this study is underway right now, and it's in 35 ICUs in France. So we should be hearing data from the CESAR study, when that gets completed. And in the US, there are two large studies under the umbrella of the INSPIRE ICU study group. Both studies are about 500 patients, randomizing them to isoflurane versus propofol in a blinded manner. This isoflurane is in a syringe hooked up with a tube. It's very interesting to see how this is done, because we are one of the major sites doing the study. But that's another study that's going to come down. So these are things that are coming down the pipeline, and I think are going to be the new frontier, perhaps, of sedation in our ICUs, because the devices to give these anesthetic drugs have been very simplified, and the scavenging systems are much better, no longer requiring the bulky stuff that we require in the ORs. So just to wrap this up, where are we now? There are new things coming down the pipeline, but one has to remember, do not forget all the evidence that we have gained thus far. In COVID, everyone thought we have to change the way we have to ventilate people. People started forgetting about the ARDSNet guidelines, etc. People started using a lot of benzodiazepines. Deep sedation started becoming common. And one has to remember to go back to all the good established literature first, and then only think about new things once they have strong data. So we know you want to assess patients for pain. You want to have an analgesia-based approach, do the light levels of sedation, see whether you can do daily awakening trials, use propofol or dexmedetomidine. Nothing is new here. We may know about inhalation agents soon. There are actually ultra short-acting benzodiazepines that are being studied. Now, old data suggests that that may not be good, but with the ultra short-acting, there may be a faster clearance, and we may not have the same problems that we have. So these studies have just started in Europe, and the FDA licensing is going on right now, not licensing. Evaluation studies are going on right now. And finally, we may get to a point where we have patient-controlled sedation. There is algorithms that are being studied for that. We may have personalized sedation once we have phenotypes done, but that's all coming down the pipeline. At this point, we know the best evidence is based on the A2F bundle or the PADIS guidelines. And I'd end with saying, stick with that. The new shiny object will come sometime. But right now, best evidence is what needs to be driven home for your patients. Thank you.